Hello to all our quality-minded listeners. Welcome to Key into Quality, a Mayo Clinic podcast focusing on healthcare quality and experience. A special welcome to our Mayo Clinic Care Network members. We're glad that you're with us. I'm your host, Dr. Tim Morgenthaler, a professor of medicine at Mayo Clinic and a vice chair of Mayo Clinic Quality. Today, we're going to talk about a critical challenge that every healthcare worker knows about all too well: blood and body fluid exposures. Now, I'm excited to have as our guests today two experts who are going to help us learn about ways to reduce the risks associated with these exposures in our healthcare spaces. Co-hosting with me today is Sherry Nemec. Sherry?
Hi, everyone. I'm Sherry Nemec, Consultation and Relationship Manager for Quality at Mayo Clinic. You know, Dr. Morgenthaler, we've had a lot of opportunities to talk about both patient safety and staff safety in our podcast conversations, but this is really the first time we've dug into this topic.
You're so right. I think we've really learned that, safety is safety without adjectives. We have to have our healthcare workers safe while they're performing things around our patients, and that keeps our patients safe. So it's a great topic. But I'd like to start with a little perspective. So Sherry, did you know that in 2017 alone, U.S. hospitals reported over 12,000 cases of blood or body fluid exposures? It's a really big deal. A lot of times people don't even report these because they're thinking it's a minor injury, or they're too busy, or the risks of infection aren't real. But we're going to learn otherwise. The good news is that we're taking action. Today, we're going to hear from experts driving solutions to reduce risk, improve reporting, and protect our teams. So let's get together with them. Today, we're joined by Dr. Melanie Swift and Seth Clarenbach. They are both from Mayo Clinic. Welcome, Dr. Swift, and welcome, Seth, to our show.
We're glad to be here.
All right. Well, Dr. Swift, could you just tell us a little bit about yourself? What's your role here at Mayo Clinic, and how did you end up doing the work that you're doing now?
Sure. Thank you again for having us. One of my roles at Mayo Clinic is Associate Medical Director for Occupational Health. And one of the programs that I oversee at Occupational Health is the bloodborne pathogen exposure program. I got first involved in this when I first started working in occupational medicine. When you do occupational health in a medical center, blood and body fluids are bread and butter. And actually, the very first patient I saw, and I say patient intentionally because we talk about patient safety and staff safety and how, there's no adjectives for safety, but actually occupational health does manage our staff, and to us,
those are your patients.
Right. So I see this work as advocating for my patients. But the very first patient I saw as I was being oriented to occupational health was a surgeon that the staff had come back to the back. We were in a meeting and had gotten a doctor. My preceptor went with me. They wanted a doctor to see this person because it was an angry surgeon. And nothing gets everyone more tense than an angry surgeon.
Right.
And so the story was that he'd been operating on a patient who was known to be HIV positive and had sustained a Sharps injury. And came at that time, people would just come over to the clinic to be seen, and was pacing in the lobby and coming back up to the front saying, I really need to get back to the OR. I've scrubbed out. They're waiting on me. I've got to get back. You've got to hurry it up. And was getting a bit agitated. When we got into the room and we began to talk, it was very clear that he was frightened, as anyone would be. This was 2001. And HIV at that time was still seen as a death sentence. It was not the manageable chronic disease that it has become since. So in my experience there, I really saw so many people just absolutely shaken to their core. I saw people cancel weddings, postpone weddings, waiting for the results of their post-exposure test. People who needed to have psychological counseling because it's just a tremendous worry.
Yeah, trauma.
Yes.
So you don't think I overstated it when I said it's kind of a big deal?
Not at all. It's a very big deal.
Yeah.
Yes. Yeah. And for each of us who sees this all the time, it can become a bit of an everyday thing, and we get a little bit inured to the risk. But for an individual staff member, this may be their first and hopefully only time it happens to them. And so we can just never forget how important it is. So I've been working with occupational health teams both here and prior to coming here at my previous institution, doing everything we can do, not only to prevent these from happening in the first place, but also to make sure that our response is timely, effective, and high quality.
Wow. If I forget to thank you later, I'm thanking you now for the work that you're doing. Okay. Hey, Seth, tell us a little bit about, your position and how you got here.
A little bit about myself. So Seth Clarenbach, I work in occupational staff safety for Mayo Clinic. I've been in the industry of safety for about 15 years and 13 of those years at Mayo Clinic. How did I get my start in bloodborne pathogens, or as we call it, the Bloodborne Pathogen Exposure Reduction Subcommittee, BEEPers for short? We had an individual that was secretary for that group about 12 years ago, and he was transitioning to a new role, and they were looking for a new secretary. Well, my name seemed to have popped up because I was a frequent visitor to display, present, and talk about data for Needlesticks and blood and body fluids for Rochester. So,
You found your fit.
yeah, do you want to be secretary for Beepers? I'm like, yeah, what does that mean? Sure, okay, sounds great. Early on in my career at Mayo, and the rest has been history. And I've seen a lot of different things happen over the years, a lot of successful and continual improvements. So I feel pretty lucky to be in the right place at the right time and being either volunteered or voluntoed. It doesn't matter to me. These are all good things. So that's
Let's jump into that a little bit, Seth. You mentioned this committee called Beepers. So, can you tell us a little bit more about that?
Yeah, absolutely. So really what the charge of the committee is to look at ways to prevent, reduce, manage, provide education, tools, and resources to employees that work in an environment where the hazard is being exposed to blood, body fluids, whether intravenously or through a splashing contact. And that's really what the main idea of the committee is. And one of the other items is that we review on an annual basis OSHA's bloodborne pathogen exposure control plan. It's just an annual requirement, but there's a lot of good elements that come from that standard that help drive improvement and help work on reducing and prevention. So there's a need for it. One of the interesting things about the committee overall, since I've been on it, even before I've been on it, is just the membership. We have members from surgery, we have members from nursing, we have members from lab medicine, we have members from waste management, from infection prevention and control, from anesthesia, from supply chain management, staff safety, occupational health services. So really the team's built around where do most of the incidents occur, or where are they experiencing a high number of them? And then, who's following up, who's managing these incidents from occupational health services? We got supply chain on there because, right, from a procurement standpoint, what about safety engineered sharps? How do we evaluate and review and get in the best products that are available that would be good for patients and also good for employees to use?
So, Seth, before we get into those very interesting questions that you just raised, I have a slightly different question. You just shared with us the wide diversity of individuals that are on this Beepers committee. But by the way, what does Beepers stand for?
Bloodborne pathogen exposure reduction subcommittee. It's always a mouthful to say, so that's why we say beepers.
Beepers is kind of fun. I'm just trying to put myself in the chair that our listeners might be. And I think you just named about 12 to 13 people on this committee. So why do you perceive that that is so helpful? Because it's an investment in manpower and resources to have that committee meet.
Absolutely. So the reason why we have such a multidisciplinary team is different areas, right? They're all experiencing the same type of hazard, needle sticks or blood and body fluid contacts and splashes, but they all have them occur in different instances, whether it's giving medication or a vaccine or doing surgical practice or even just emptying garbages or even just supporting this is what we need to buy. Well, we got to get review from everybody from that multidisciplinary team that may use that product. So it's just a wide expertise to have on the committee because that topic touches so many different groups.
So, Dr. Swift, maybe we can explore a little bit more about What areas experience the majority of exposures at Mayo Clinic?
Well, it's largely where the sharps are, which is, operative services and other procedural areas. It's also where things may be chaotic. So trauma, so the emergency departments will experience that. High volume areas. So largely this is pretty consistent across the hospitals. It'll be, your period operative and emergency department areas will be your highest risk for sharps injuries. Splashes also occur just in any general inpatient areas. People are emptying drains and starting IVs and doing procedures. So it's really all over the hospital, but definitely those perioperative areas lead the way.
So obviously, the work that you and the group is doing is really trying to, right, reduce when those things happen. So what are you finding maybe that's you're exploring or working in order to drive that change to reduce injury?
It starts with trying to get some data on what's actually happening. And that's what the committee does, is really looks at what are the patterns that we're seeing. And that might be by area, that might be by type of procedure, that might be related to a specific device, or it might be at some point in the process of patient care. So one of the things that happens when you report the injury, you either talk with one of the nurses who takes our calls here at Mayo, or you'll be putting in your incident report, and we can talk about how we're helping to make that all talk to each other so that it reduces duplication and makes things more efficient. But one of the questions is, what were you actually doing at the time of this? So it's things like, I was activating a safety device. And that actually happens. It's not an uncommon cause of injury for certain safety devices. Makes you say, oh, we need to look at that safety device, right? But sometimes it's after use before disposal. That means, okay, I've used the device, I'm trying to put it away. And between the bedside and the sharps box, something has gone wrong. So it might be patterns like that. In the early days, we would find a lot of those after use before disposal injuries, and it's because sharps boxes were all the way across the hall, sometimes not even in the room, right? And so you've got a sharp that someone's running around with, or laying down on a tray and someone else is then getting it to dispose of. It might be during a surgical procedure. One of the questions that's asked were you the original user of the device? And when that answer is no, that tells us we have a problem with management of sharps in the surgical field or with disposal of used sharps, right? So hands-free passing is something you've probably heard of, and Seth could really speak to this in more detail. But that's a red flag that you need to look at how instruments are passed from person to person, or how people can get their hands in the way of a pass.
Seth, maybe you can give us a story or an example of one of the incidents that was sort of evaluated and how you found that there were some technique problems.
Sure. I won't be able to give a specific case example, but just a broad scenario. So, uh, to speak a little bit more into the data that we collect and look at and review and analyze, I want to go on to further say, just what Dr. Swift was going with, right? We're able to slice and dice all of our data, and we've worked with various groups, one in particular, surgical services, and we're able to narrow it down to St. Mary's campus, certified surgical assistants, and work with that group and even just understand, what areas are they supporting? Is it cardiac? Is it thoracic? Is it ortho? Is it general? Is it neuro? Is it urology? We were able to work with that supervisor and those employees to work out, why are we seeing such a high amount of injuries with needle sticks, and what can we do to bring those down? And, it was awareness. It was getting the hands-free passing topic out there and initiated. I know it's been talked about in the community from a surgical perspective, but how do we apply that and how do we implement it? And it takes a team to do that. It's not just going to be a certified surgical assistant. It's going to be the surgeon. It's going to be the resident. It's going to be the surgical tech. All people in that operating room are a team, and it takes a team to make hands-free passing work. It doesn't work all the time. It's not 100% thing that you can do in the operating room.
Human involvement.
Yeah, there's going to be certain procedures where it makes no sense to do, where you really can't take eyes off the field, or you've got a magnification for eyesight, from the surgeon's point of view, where they got to be looking in at what they're doing. They got to hand back the instrument. So those are, the short and few cases. But if you figure it out and work at it and try and implement it, you can find that most of the time, this is something that can be achievable. Really, what the hands-free passing is you have essentially a neutral zone, whether it's a flat surface or a metal basin or a Mayo stand. And whoever's using the instrument in the operating field, they put that used instrument in that basin or on that desk or on that surface, and then they let go of it. And then the next person who needs to collect it can pick it up. It's not a hand back and forth. Where we see some of those incidents come from, and whether it's the person who's handing it, they stab themselves because there's a fumble, or if the person who's taking it from them gets stabbed as well or poked. So it's kind of an efficient way to do that type of practice and do hands-free passing.
Yeah. So you've learned some procedural best practices. What technical or engineering changes have you seen recently that reduce the risks?
I have an example that actually happened before I got to Mayo, but I think very similar things happened here. In looking at the patterns of injuries, we found that across the whole inpatient area, we were seeing injuries happening while disposing. We talked about that activating safety device between use and disposal, but there's also during disposal. And so that caught our eye and prompted some rounds on the units to look and talk. And also that committee structure is so important, because then you have people who work in the area, know the environment, know what's being done, and they could say, oh yeah, you should look at these. So we went to these sharps boxes and found that what was being used at the time were called straight drop boxes. And you'll still see these, where you just hold the sharp over a slot and you let go and it drops straight down in. The problem with those is that if it's overfilled, and it can be hard sometimes to tell how full the box is, or if something really long had been used before. So say a guide wire from a central line or something like that, you'll have something that's sticking up just out of view.
Mm.
And so someone who goes to dispose of a syringe, say, and puts their fingers right in the top, they get poked. So what we did with the committee at that time was to pull in our folks from procurement and look at the variety of sharps boxes that were available. And then you have people trial the different ones. Can you operate this one one-handed? Is this large enough to meet your needs? All the different factors that really need user input have to be collected, whether it's a safety device or sharps box or really anything else we're using in patient care. And they found that the letter drop style, where there's this little tray at the top with you can't see me on the podcast, but I'm making a little squeaky with my hands, like a little curved half cylinder at the top, that you set the device in, the syringe, for example, and then you bring your hands away and you tilt it so that it drops in to the box.
Almost like a mailbox.
Like an old-fashioned mailbox, exactly. So the letter drop style is what was selected. Then there was a phased, implementation of replacing all the old boxes with the new boxes. You have to make a business case for that kind of a thing. But when you can demonstrate, look, we had, 60 exposures over this time frame that could have been prevented by doing this. And you look at, and this is something I'd recommend to anybody who's looking at their program, find out what each exposure costs you. Because there's not only the mental anguish that we discussed earlier, but it's lab work for the source patient. It's lab work for the individual who's exposed. It might be post-exposure prophylactic medication, follow-up visits, etc. And that's if everything goes okay and they don't get an infection.
Yeah.
If they develop an infection, it's incredibly costly. So you can really make a good business case and invest in improvements based on the reduction in injuries.
I think you're right. I mean, I think we have to take into account this is personally expensive, it's financially expensive, and it's culturally expensive if you want to think about what the organization is doing to address the safety of the worker here.
Any other barriers that you're running into? Anything that still causes you concern? Something you want to share? And just probably our listeners are having some of the same challenges.
I think it would probably, and Seth, let's see if you agree with me. I think it would be what Dr. Morgenthaler alluded to at the beginning. It's underreporting. I think people, of course, there are barriers to reporting. You have to stop what you're doing. And if, by the way, you're going to need HIV post-exposure prophylaxis, that has to be started within 2 hours to be its most effective. So there's a time pressure, and healthcare workers are busy. No one has an extra 10 minutes to go spend on the phone and another 10 to go to the pharmacy and all of that. But the reporting is so important because even if your exposure is low risk, it allows us to identify these patterns. It allows us to implement changes that'll then prevent somebody from having even a higher risk exposure. We know that there's a lot of underreporting. We also know that it tends to be, there are patterns to it. So pediatrics, among physicians, pediatricians are the least likely to report their exposures. Actually, surgeons do the best. and that has to do a lot with perceived risk, right? And so I think that's still what I see as one of our biggest barriers is we've got to, we continually work to make reporting easier, to make it less time consuming, but there's a certain amount of time that it's going to take. And reporting that helps not only the individual who's exposed, but it really helps all of their colleagues to be protected in the future.
So Dr. Swift and Seth, we're really fortunate to have you two here, and we have, experts across much of our system. And as a, larger healthcare system, I'm sure you lend your expertise to some of our smaller facilities as well. What would you say to an organization who wants to start to work to improve this area in their locale?
I mean, could I add on to what Dr. Swift was saying about barriers to reporting?
Absolutely.
I've got just a couple items I'd like to throw in there, but Dr. Swift, completely agree with the barriers to reporting. It takes too long for the report to fill out. It takes too long to complete. But also add and throw in there, and you touched on it, is risk acceptance. Is a lot of staff, and I don't have the data for this, but come into the healthcare organization and there's a risk of acceptance of, yeah, I'm probably going to get poked, or I'm probably going to get a slice that has blood and body fluids in it because I work in surgery, right? I work with knives and I work with humans all day. There's an acceptance to that. How do we take what, I know this podcast is not about workplace violence, but how do we take workplace violence did, the underreporting or the non-reporting, to what we see today, which is significantly more reported? How do we get the staff to say, you know what, this is not acceptable for me to have this risks in the workplace? And how do we change that? And it's definitely a culture change and a culture shift. So I just want to throw that in as something that would be really good takeaway, not only to add on to what Dr. Swift was saying, but also the question of, what's next? How do we continue this improvement?
Yeah. So what would you say to an organization that wants to start work or improve in this area?
There's going to be a variety of elements to look at. It's really to understand what's your current state and how do you understand your current state. First and foremost is, what data do you have? Does the data help you tell a story? Does it help you understand where your pain points are and where your problems are that are existing? And once you know that information, there's a ton of information that you can go out and research, whether it's on the NIOSH website from the Stop Sticks campaign, which has a variety of items to follow to help reduce and prevent needle sticks and blood and body fluid splashes. They give you a game plan to follow. But right, where are you seeing these issues? And then you could start to focus on those areas and understand more, why are we doing it this way, or what is it that we're using? Is there another product out there that's more safety engineered that might give way to seeing a reduction of injuries? So you really got to start with understanding the situation and the current state and what's happening, where's it happening, who's it happening to, when is it happening in the process or the procedure, what was somebody doing, what task were they performing when they were doing it. So it's that's where it starts.
Yeah. Anything you want to add, Dr. Swift?
I would add two things to that very good start. One, to follow on the data, is that I think a lot of institutions get a little bit stymied because they worry about benchmarking. How do I benchmark to know if my rate is high or my rate is low? And the truth is that this is not a really helpful exercise. Organizations may use different denominators. They might count the number of heads, they might count FTEs, they might count the number of occupied beds, they might count the number of sharps procured and used. Really just start measuring yourself, because you're different from every other hospital. I mean, there's similarities, but hospitals have differences. If you're a surgical center,
Very true.
you're having more, right? And then make iterative changes over time against your own baseline. The second thing is to go back to what Seth was talking about with the composition of the Beepers committee, is that you need stakeholder input and feedback, and you need them to be ambassadors in order to implement a change like hands-free passing or double gloving or blunt suture needle or anything like that. Seth can't do that. I can't do that. That kind of change can never be driven by your safety experts or your occupational health consultants or anyone. It can only be driven by the people, the leaders on the team doing the work, right? So get as much buy-in as possible, identify people who are safety focused and quality focused and who are leaders in the practice, because we have to respect that they know what they are doing and they are concerned about the global safety of the patient and themselves and their team. But we've got to feed them back the data that's actionable, that lets them decide the best changes to make within their practice. So I think it's a real partnership. It's powered by data and by relationship.
Great points.
Wonderful. Well, listen, you two, I just can't thank you enough for joining us today and sharing your wisdom and your experience. And you've given some great pointers to other organizations to think about how to approach these problems. We'd love to have you back another time, but for now, thank you so much. And I'd like to express my gratitude for what you do for us as employees at Mayo Clinic. Thank you.
That's right.
Thank you for having us.
So I think that's a wrap for this episode in Key into Quality. We hope that you found it insightful and useful for tackling quality challenges in your organization. If you enjoyed our podcast, please leave a review on Apple Podcasts, rate us on Spotify, or share your thoughts wherever you listen. And don't forget to spread the word. Better quality starts with all of us. Thanks for tuning in, and we'll see you next time. Goodbye.